Hello, I'm Mark Litto. I'm an actuary and spent most of my professional life as a principal at Milliman, one of the nation's largest actuarial consulting firms. This webcast is the third of 3 analytical assessments of factors affecting America's healthcare. If you have not already seen the first or second webcasts, Big Numbers and Big Benefits, I would encourage you to do so before watching this program. If you've already watched these programs, thank you. And now once again, let's get started.
In all of these presentations, we highlight the conclusions we think critical to inform discussion of healthcare in America and share examples of the data and research findings that support those conclusions. When talking about the magnitude of the numbers, for example, we make the points, among others, that future healthcare spending will require a significantly larger and arguably unmanageable share of both individual household and government budgets. The options being considered for changing the Affordable Care Act do not adequately address the needs, complexity of, or financial stability required by American healthcare, and that the country can't find the answers we need without considering the demographics, the economic realities, and a host of equity issues, including the shifting of costs to future generations. Building on those conclusions, in the Big Benefits presentation, we made the points that the public tax-supported programs that account for roughly half of all healthcare payments do not meet basic risk management criteria and should not be viewed or managed as insurance products. The public programs are not financially sustainable as constituted, and that the allocation and distribution of payment of benefits has led to a series of use-driven distortions in America's healthcare system, which, we concluded, are placing a very significant burden on the cost of doing business in the United States and eroding the quality of life in this country by forcing major damaging cuts in revenues for state and local services and funds needed for education. We feel obliged to start this Who Pays presentation with a spoiler alert, which is that the American healthcare business model is simply not working. Putting that conclusion in context requires taking a look at the basic value proposition that covers what most people seem to be saying they want when it comes to healthcare. That is, that in America, everyone should be able to get the healthcare they need when they need it. There are 3 deliverables implied in this proposition. The first is that access to quality care must be assured. The second is that care must be delivered in a timely manner. The third is that the delivery of and payment for health care will be triggered by a need for care, which raises the point that the system has a responsibility to define and delineate what constitutes need and how we define timely. Making good on the value proposition requires linking it with a management and delivery proposition. For example, it seems reasonable to suggest that in America, the system responsible for making good on the healthcare value proposition must be sustainable and the costs should be allocated fairly, which means that the main components have to be clearly identified and that the role of each of those components be defined and assigned. It also means that the costs must be transparent and that the financing be reliable over time. Determining whether or not financing is reliable requires looking not simply at ability to pay in any given year, but also considering ability to pay over time. This latter point is critical, for example, in determining whether a program such as Medicare is having its cost being appropriately amortized from available revenues over time, including from FICA and other sources. Despite a long-standing tendency in America to talk, debate, and argue about the value proposition and the statement of operational requirements as though they were separate intellectual topics, they are in fact inextricably linked, and we need to recognize that in America, everyone is not able to access the care they need because the system, as currently operated, is simply not sustainable. More specifically, one of the reasons that the business model is not working is the numbers don't work in terms of sufficiency or sustainability. Consider, for example, the nation's ability to sustain its healthcare commitments as enrollment, cost, and usage numbers changed and expenditures increased. We touched on the question of fiscal sustainability in both of the first 2 presentations, but we can add some depth to the issue here by comparing system costs pre- and post-Medicare and Medicaid. In the slides you are about to see, We've adjusted for inflation and are showing average per capita costs in 2017 dollars for 1960. That is, before Medicaid and Medicare existed, and in 1990 and 2017 when both programs were operating. Expenditures climbed primarily because more people were receiving care and because more people were seeking more care. For example, if we designate 1960 baseline data for insureds as 1, we can see that hospital outpatient and clinic physician frequency of use is up. More specifically, we can see that length of stays in hospitals has dropped, but the number of visits to clinics has doubled, and not surprisingly, costs, including charges for services, have gone up. Costs reflecting reimbursement rates before discounts, that is, retail charges, and weighted to reflect age, income, benefit design, and other factors, suggest that costs on this basis nearly tripled between 1960 and 1990, and then grew by more than 4 times as much between 1990 and 2017. You may remember from our big numbers presentation that between 2008 and 2017, Medicare and Medicaid enrollments increased by 40 million people. Facing rising costs, both governments and private insurers began to escalate differentiated discounts to various populations, while retail prices soared. This change may or may not have affected what care actually cost, but certainly affected what providers were paid for specific types of care. For example, the reimbursement rates set in 1990 paid approximately 90% of retail charges. In 2017, that average reimbursement rate had plummeted to 38%, with huge differences between market segments. By way of comparison, if the roughly 400% increase in healthcare costs had paralleled net growth in wages, that is, growth over inflation, which was only 40% during the same time, average 2017 per capita costs for the insured's population would be less than $2,300. Had healthcare costs kept pace with wages between 1990 and 2017, they would have been approximately 73% lower, and it is legitimate to ask how consumers might have spent that roughly $6,200 a year differently, and what that might have meant for the economy as we went into and through the Great Recession. This dramatic deterioration of affordability relative to wage growth parallels the dramatic use of large discounts in healthcare and the many unintended consequences noted previously in these presentations. The system's lack of sustainability is also affected by the fact that its current demand for revenues is forcing governments to reduce support for other public services. Note, for example, that Medicaid alone now consumes 67.5% of every federal dollar going to state and local governments, including, up from 55% just 8 years ago, an increase that parallels, for example, a significant decline in state and local infrastructure investments. And despite the huge reductions in reimbursement paid by governments to providers, the taxpayer-supported programs are in ever-increasing distress. In 2017, for example, using government-reported information, not counting dual-eligible individuals, we estimate expenditures in excess of revenues of $234 billion for Medicare and $487 billion for Medicaid. And those patients with both Medicaid and Medicare coverage incurred costs nearly $410 billion more than revenues. That's combined expenditures over revenues in excess of $1 trillion. And, as we noted in our big benefits presentation, efforts to deal with the lack of sustainability and sufficiency are affecting people's ability to get the care they need when and where they need it, suggesting, for example, that more than 12 million Medicaid patients don't have the access they need, and raising serious questions about whether or not rural patients can find the care they need when they need it. On top of all this, the current financial realities and future projections indicate pretty clearly that a significant portion of these costs are being levied for payment on future generations. For example, healthcare accounted for approximately 36% of federal spending financed by general revenues in 2017. Therefore, roughly 36% of the 2017 federal deficit, or about $240 billion, was attributable to healthcare in 2017. That's nearly $250 billion we are handing off to our grandchildren just due to our healthcare system, and that's for just 1 year. The next point we need to make as we consider who pays is that there are political and financial tensions in the American healthcare system that work against the system's need for public awareness, accountability, and capacity to address problems in a timely manner. It is important to note as we approach all of these issues that payments made directly to providers come from one of 3 direct payer categories. The first category consists of private sector third-party payers. That is, insurers or self-insured employers who pay benefits on behalf of individuals covered by health insurance plans and policies. The second category consists of government agencies that pay claims authorized under government programs including Medicare, Medicaid, CHIP, and the Veterans Administration. The third category of direct payers are individuals who pay a portion of their health care costs at time of service out of pocket, including deductibles, co-pays, co-insurance, and certain services not covered by third parties via private and social insurance. Government payments are supported primarily by revenues from federal payroll and income taxes, state income and sales taxes, and Medicare Part B premiums. Private sector benefits payments are supported by revenues from premiums. Government, in turn, subsidizes some individuals by transmitting a portion of their individual health insurance premiums and co-pays to insurers by means of ACA premium and cost-sharing subsidies. Looking at the various revenues to third-party payers, it is important to note that people are the source of all of them. Employees are the source of all payroll taxes, since payroll taxes, both employer and employee portions, are employment costs. Corporate income taxes are costs absorbed by shareholders, who are individuals in the final analysis. And individuals are the source of all health insurance premiums too, as employer-provided health insurance premiums, like payroll taxes, are also employment costs. Employers, governments, and insurance companies serve largely as financial conduits and administrative intermediaries between the people who collectively receive and pay for health care and the providers of such health care products and services. The previous slide shows how the $3.5 trillion in HC costs paid into the system by people are ultimately paid out by the system at or after time of service by the 3 direct payer categories: individuals, government, and private insurers. But it does not show how those costs paid and services received are split among broad groups of people covered by the various types of benefit programs. As you can see, those covered by the primary government health care programs, Medicare and Medicaid, receive about $1.132 trillion more in benefits from the system than they pay into the system in the form of premiums, taxes, and out-of-pocket costs. For the Medicare and Medicaid programs, we have broken out the 11 million dual eligibles in a separate column. Those covered by secondary programs, including veterans, are subsidized by an additional $104 billion. Looking at those not covered by such government programs, but who have to pay for their own coverage, we get the reverse picture in terms of net subsidies. About 160 million are covered by employer-sponsored health insurance, which some would argue they pay for via their pay package, while 16 million are covered by individual health insurance and 28 million are uninsured. These groups of people subject to coverage from the private side of the equation live a very different story, as the premiums, taxes, and out-of-pocket costs that they pay exceeds the benefits they receive from third-party payers by the same $1.237 trillion. These groups collectively subsidize the other groups. However, it should be noted that some wealthy individuals covered by Medicare pay much more in taxes than they receive in benefits, while some individuals covered by ACA receive more in benefits than they pay in taxes and premiums after their ACA subsidies are factored in. So, when we go back to our cost and benefits flow chart, what we see is roughly $1.2 trillion in subsidies being transferred from those not covered by government health care programs to those who are covered by them. This fiscal imbalance between private and government outcomes, as well as the aggregate deficit incurred and covered by borrowing, generates political and financial tensions. These tensions are particularly noticeable between private insurance market participants required to cover their own costs and at the same time generate positive cash flow to subsidize others, and participants in government programs that have operational challenges subject to and driven by government decisions about who gets what types and levels of care, how much the government is willing to reimburse providers to provide such levels of care, and how much the government is willing to impose on taxpayers via its taxing powers, all of which obscures the actual costs of government healthcare decisions and where the money comes from to pay for those decisions. When taxes go up, for example, the fact that they are going up to pay for healthcare costs is not clear. Nor is it clear when revenues diminish for other governmental programs as deficits accumulate and must be paid off, that those cuts can continue to be made to cover governmental health care losses going forward. The process also distorts understanding of the cost of private insurance because when changes in governmental reimbursement rates push providers to raise prices for the private insurers, most people do not understand that part of the cost of governmental health care costs are being paid through their private insurer premiums. Those reimbursement rate reductions also distort our ability to see, let alone understand, the cost of care in our country. And finally on this point, the current process either significantly diminishes the amount of revenue left to meet other public needs or compels a transfer to deficit funding not only for those in the next few years, but to future generations who will see the effect of a cumulative buildup of debt with interest. And with projections that suggest healthcare spending will increase by $1.6 trillion per year by 2026, there will be even more bills that will burden generations to come at both the household level and the government level. What all of this suggests is that the distribution of services, costs, and payments on the one hand, and collection of taxes, premiums, and fees to fund the payments on the other, does not effectively recognize or manage either the differences between insurance coverage and different types of subsidized care or the redistribution of income required to support the subsidized care. Let's start our examination of this critical premise by looking at estimated income distributions within each of our 5 major groups by type of coverage. The group private insurance population, shown here, represents about 54% of the total U.S. population of 300 million. As you can see, we have broken our estimates into 4 key income groups, including in descending order of income the top 1%, the next 49%, the next 35% of all earners, and the bottom 15% of earners. For this large group with employer coverage, approximately 2.3 million people, or a little more than 1%, fall in the top 1% of all earners, with another 115.7 million people, or 72%, in the next 49% of all earners, for a total of 118 million in the top half of income. When we look at the individual market, we find about 6% of the population, but notice here that we estimate this user group has only 30% of its population in the top half of earners, and 70% in the bottom half of all earners, with more than 1 million people in the bottom 15% of earners. The Medicare population has 60% of its members in the top half of income, with a little less than 1 million in the top 1% of earners and more than 3 million people in the bottom 15%. Conversely, more than 90% of the Medicaid population fall into the bottom half of earners, with more than half, nearly 37 million people, in the bottom 15% of all earners. And likewise, almost 90% of the dual population falls in the bottom 15%, while the remainder are in the 50% to 85% category. When one looks at the income makeups of the various user groups side by side, it is apparent that gainful employment, past and present, is probably the major factor affecting income distribution. When one revisits the cash flow numbers we viewed earlier, it is clear that while income contributes to positive revenue balances, usage contributes to negative balances. With that in mind, let's look at the per capita amount each of the different income brackets contributes to pay for health care in America. Here are the per capita net subsidy payments per income brackets. The top 1% are contributing more than they receive in benefits by about $47,000 per person. The next 4% by income are contributing about $10,000 each in subsidies, while the next 45% are subsidizing by about $6,400 per person. By contrast, the bottom half of earners are receiving about $7,500 per person on average in subsidized benefits. Total subsidy estimates indicate that the top 1% are contributing about $150 billion in subsidies, while the remaining 49% in the top half of earners contribute roughly another $1 trillion. When one looks at all of these numbers, it is not surprising that the nature of the health care required results in per capita payments that are considerably higher for the elderly and those who qualify for Medicaid. But, from a responsible management point of view, it is surprising that the system has not done more to acknowledge the imbalance of revenues and done more to address that imbalance directly at the program level. Keep in mind that these are just the dollar costs. There are other costs related to access, availability, quality of life, generational equity, and lost opportunity that we have commented on throughout these presentations.
Thank you for watching this introductory series on the challenges, opportunities, and possibilities facing the American healthcare system. As you might expect, covering an issue as broad and complex as this one is not easy, particularly when you're trying, as we are, to present the information in an easily accessible way intended to become part of a growing library of resource materials dedicated to encouraging and expanding public understanding of and engagement with the fiscal and managerial factors affecting their and the nation's healthcare. We are dedicated to this effort because we believe that a very different, more informed conversation about America's healthcare challenges, opportunities, and possibilities is essential. We hope that these three programs, Big Numbers, Big Benefits, and Who Pays, will jumpstart that new conversation by providing interested citizens like yourself with a range of information and by drawing attention to the data-driven observations, assessments, and concerns that we believe must be at the heart of that conversation. To that end, let me summarize what we think are the four most important takeaways from the three programs. First, we literally cannot afford to continue to kick the can down the road and Band-Aid philosophy we have now followed for many years to address what is wrong with the current healthcare system. The massive financial demands and the well-intended but narrowly focused reactive management of the current system are already adversely affecting the quality and availability of healthcare in the country and eroding our national and household quality of life by diverting vast sums of money from necessary investments in education, infrastructure, and social services. Second, the development of a sustainable, accessible, effective healthcare system most people appear to want requires a far more holistic assessment and understanding of problems. Once the problems and needs of all parties are recognized, we can then debate and ultimately construct a vision for the efficient use of resources, including mechanisms for allocating corresponding costs in an equitable manner that recognize the need for generational equity. Third, we need to distinguish between the roles of insurance coverages and subsidies and how private and government revenues and expenditures fit that role. In doing so, we need to ensure that the amortization schedules for insurance programs are realistic and that subsidized care supports broader efforts to help people improve their lives. Fourth, the magnitude of the public and private dollars spent on healthcare requires that, first, the pricing of services, drugs, and care be rational, understandable, transparent, and meet medical needs while satisfying affordability concerns. And second, support for subsidized care recognize and be linked to the need to encourage greater patient awareness of and sensitivity to the relationship between cost and usage. A final thought for your consideration. The data makes clear that our capacity to pay for the healthcare we want is ultimately dependent on our having a workforce large enough and sufficiently compensated to pay for the care they need and to subsidize the care others may need on either a short-term or chronic basis. As we talk about addressing America's healthcare challenges and opportunities and possibilities, we know that helping people succeed economically improves the system's sustainability and affordability. We might also want to recognize, as we go forward, that a growing body of data suggests that helping people do well financially may also be one of the single best things we can do to improve their health. In the months ahead, the concerned actuaries and the Committee for a Responsible Federal Budget will be producing additional materials and hosting discussions about these issues. We hope you will join us. Thank you.